is currently regional editor and also a mobile member in Australia. He will talk about the management of film to major division like this.
Thank you very much for the kind introduction, and thank you very much to the VSIR Society and themselves for the kind invitation to join me. I'm going to give a talk about the management of failing to mature AVF, which is a very big problem and a very challenging issue for interventional radiologists. And these are my disclosures. So taking a step back, we know that AV fistulas are vastly superior to both central venous hemodialysis as well as AV grafts in terms of mortality, infection, reoperation risks, the annual cost of the patency. So they really are the gold standard of dialysis access. So we really need to maintain AV fistulas where we can. Approximately about a quarter to almost half of all new created AVF fistulas fail. And that's usually due to a failure to mature. But there are other reasons such as thrombosis. We've heard Jackie give an excellent talk on thrombosis of fistula. But interestingly, we're seeing this incidence of failure increasing. And it's not because the technique has changed. The technique of fistula creation has remained relatively stable. But we are starting to dilate patients who are much older. And so we're seeing more comorbidities such as atherosclerotic disease, such as other diseases that make the arteries harder, the veins more sclerotic. So therefore we're treating more challenging patients. And the way in which fistulas mature is poorly understood, although we have quite a few theories of how this works. So when we create a fistula, we're arterializing the venous system. So we're creating the venous system to suddenly become very high flow, to take a lot of pressure. And this increases the amount of something called shear force and also a circumferential stress within the venous wall. And we want to create that because that will hopefully end up creating outward remodeling. So we want the vein to dilate, to be able to become larger so that we can have access to this vessel. If we have a quick look at the structure of the artery and the vein, we'll remember that there are three layers of vessel walls. There's the intima, which is a very thin layer of endothelial cells. Then we have the tunica media, which is the bulk of the vessel, which contains most of the connective tissue as well as these muscles. And then we have the tunica adventitium, which covers the external portion of the vessel. And so like we said, that when we create a fistula, we're creating an increased flow situation in the artery because suddenly there's a reduction in resistance, so you see more blood going through the artery. And we're also seeing a rapid increase in the pressure and the flow through the vein. And so what that does is it causes two things in the vein. First of all, from this stress, we are stretching the vessel open, and that causes some stretching of the media. And so as it stretches, it gets bigger and bigger. But as it stretches, it causes inflammation. And inflammation then attracts things such as fibroblasts, as well as inflammatory markers. And then we get some intimal hyperplasia, as well as a vascular remodeling response. So it's a balance between how much the vessel stretches to how much intimal hyperplasia there is that narrows the vessel that leads to caliber change within the vein. The other thing that there's been some research is to look at the turbulence or the blood flow parameters within fistulas. We know that if the angle of the fistula is different, such as at the bottom, whereas it's more of a right angle, there are different pressure forces on the vessel. I won't spend too much time on this, but we know that we're creating an unphysiological condition here, and there are different stresses on different portions of the vessel. So what we'll find is that most of the disease for failure to mature AV fistulas comes at the anastomosis, because that's the area that receives most of the shear stress. So most fistulas mature within 4 to 6 weeks, And interestingly, as soon as the anastomosis is made, about 50% of the total flow starts immediately. And the Kadoki guidelines really say that we need to monitor these fistulas, particularly in the first 4 to 6 weeks, because if we can intervene on them early, outcomes are much better. There are lots of definitions of what makes an immature fistula, and it all depends on the institution. This may rely on things such as a low Doppler flow rate. Some units use less than 300 mils per minute, some use less than 500 mils per minute. Can the fistula be accessed? How often can it be accessed? The Kadoki has the rule of 6s, and I'm sure a lot of you are aware of that. For the ideal fistula, we need a flow greater than 600. The vein needs to be 6 millimeters in diameter, and it should be quite superficial of less than 6 millimeters from the skin. But generally, any fistula that's about 3 months old and is not functioning well is what we would consider a fistula that's venously mature. Lots of different causes. We've talked about stenosis. By far the most common is within the anastomosis and the outflow vein, or the usable segment. We shouldn't forget about central stenosis or arterial inflow disease. Some patients might not have been worked up well enough. We hope that that isn't the case, but we always need to look for things like that. We've heard from Jackie about thrombosis, and the rarer causes are things such as infection and rupture. And treating immature fistulas is very different to mature fistulas. We know that first of all, the veins are smaller caliber, and there quite generally is not a dominant draining vein in these immature fistulas. So when we do our venogram, our fistulogram, we will see something like this, where it's hard to determine which is the main draining vein. What we'll find is that there are less highly resistant fibrotic lesions because the fistula is a lot younger than a mature fistula. And we don't see those large aneurysmal segments that tend to collect a lot of thrombus. But what we'll find is that when a immature fistula thromboses, they're a lot easier to treat because they're usually quite straight vessels that thrombose, rather than these large aneurysmal segments that can be quite challenging to treat. So what can we do to treat these? And so this is a paper in 2018 that was a review of the literature. And most of us will perform an angioplasty. And so when we look at the clinical results of an angioplasty, mainly of the anastomosis, or the juxtarenal region that's within 5 centimeters of the anastomosis, we can see that the clinical success is usually quite good. It varies between 43 to 97%, with 1 year primary patency, depending on the paper, of 28 to 72%, and 2 year primary patency of 68 to 96%. That's with assisted primary patency. And interestingly, they found that the best results are with a balloon around 4 to 6 millimeters. I think it's because we want to aim to get a vein of around 6 millimeters. And when we compare these results to mature fistula intervention, we see that the results are reasonably similar. We see similar clinical success rates, 1 year primary patency and 1 year assisted patency. So we know that angioplasty works. There are some other techniques that we sometimes use when angioplasty doesn't work. And so there's a technique called balloon-assisted vein maturation. And what this involves is that what we do is that we gain access to a fistula. We then slowly angioplasty the outflow vein to help dilate it. A bit like for the ellipsis device that Professor Tay talked about, we gently stretch the vein first. A week later, we come back and we stretch the vein even further. So you're artificially creating this vascular outward remodeling. The clinical success rate varies. In some papers it's about 50%, some it's as high as 89%. And the complications include the formation of hematoma, and it's quite high because you're stretching the vein. With rupture and thrombosis rates significant, but not very high. So this is a technique that we sometimes use if we find that there is no underlying stenosis, that we can sometimes help to assist the vein maturation. The other technique that we seldom use at my hospital is the accessory vein embolization. So this is where we would go and do our venogram, we would find all the minor vessels that are draining and we go and embolize them, or surgeons could ligate them. And that helps to force all the blood through one or two major veins to help dilate it. Unfortunately, there's not very strong evidence in this area. There's maybe only 2 or 3 papers that show some reasonable results. And it's not something that we commonly do, and I'll talk about why in a second. In terms of drug-coated balloons, we've heard a great talk from Gerard about drug-coated stents. But interestingly, there's very little literature about drug-coated balloons in virtual fistulas. In fact, one of the only papers was published by a Taiwanese group just last year that looked at 25 patients and found that the target lesion primary patency was about 68%. But most of the data we gain from using drug-coated balloons are from mature fistulas, of which these are 2 meta-analyses that I won't go through too much of the results, but we know that drug-coated balloons do produce a much superior outcome to normal balloon angioplasty. So we think there perhaps is a role for drug-coated balloons in fistulas that haven't matured, but there isn't enough evidence at the moment. Now finally, what about surgery in Jackie's domain? So first of all, I'll say that there are no randomized control trials that compare surgical reintervention versus endovascular rescue. But interestingly, when we look at all the surgical techniques of anastomosis modification, whether or not that's revising the anastomosis or re-implanting it, whether or not we perform vein dilatation or ligate the veins, the 1-year primary patency of surgical fix is 68 to 78%. Versus endovascular, which ranges between 28 to 72% with an average of 49. So what you can see here is that surgical revision is superior in the small amount of studies to endovascular rescue. So you might ask, why do we even bother with endovascular rescue? And so first of all, there is no randomized control data. There are a lot of case series. But similar to interventions within the leg, if we do endovascular rescue, it still gives us the option to operate on the fistula later if it still fails. So it's a generally quick procedure to do. We're interventional radiologists, so we like doing it. But it also saves the option to go to surgery later. And the Kodoki guidelines themselves acknowledge that there's no strong data to support surgical revision over endovascular rescue. But in my institution, we tend to do endovascular rescue first and then save surgical reintervention for later. So a couple of cases. This is a creation of a radiocephalic fistula. As we can see, we talked about the lack of a major draining vein. We're seeing lots of different veins here, so it's difficult to identify which is the main draining vein. But we can see here a micropuncture sheath, and at the anastomosis and juxta-anastomotic region, we see lots of stenoses. From here, we use plain balloon angioplasty, and we actually followed up with a drug-coated balloon that I didn't take a picture of. And we can see here that actually there's quite a good result. So this is a very straightforward fix. In this next case, again, another radiocephalic fistula. Again, we see this network of multiple draining veins. We can recognize perhaps there's one major draining vein. You can see here that this required 2 punctures. With my initial puncture on the left-hand side of the screen, we wouldn't be able to treat the stenosis leading up to the chirurgery. So what we did here is that we then accessed this, placed a balloon over this region, again a drug-coated balloon, and we can see here a very good result. And in fact, we see less of the other smaller veins starting to drain the fistula. And so the final case I'll show, I'll never forget essential stenosis, particularly in patients with long-term catheter dialysis. In this particular patient, they had quite a bad central stenosis that we had to use a high-pressure balloon. You can see here that it's not even wasting, so we did a cutting balloon eventually with a good result. But always keep in mind about the central stenosis because sometimes it gets missed. So in summary, treating failing to mature AV fistulas is something that we're doing more and more often because the incidence of failure is increasing. We do recommend close surveillance, particularly within the forceps, and intervene early because if you can rescue a fistula early, there's a higher chance people will survive. We adopt an endovascular approach, which I do recommend, and whilst DCBs are available and we commonly do use them, they do probably have a role, but we don't have quite enough evidence as yet. Or if anyone would like to do some trials about that, there's a good space to get more evidence. Thank you very much.